Good afternoon. It's Matthew Holt, and you're joining me on a Zoom. And if you're watching this on video, my Zoom is going very crazy these days. I've seen it happen to a few people, but nonetheless, this is the THCB gang. I have a fun lineup of today, skewing a bit old and male, but a fun lineup to discuss what's going on in healthcare in the week. And I'll tell you who is on. Okay, I have Ian Morrison, health futurist from Menlo Park, California. Mike Magee, medical historian from Connecticut. Mike Millenson, president of Health Quality Advisors, all the way over from Chicago, and holding up the winter end is Vince Kuraitis, a consultant and platform advisor. Gents, how are we all doing?
Good to be here.
I apologize. I'm having this weird thing on my screen that's going to come off and on, and I'm going to sort of stop and start my video all the time, and we'll just see what the hell happens. But anyway, that's where we are. It's been quite a week in my personal healthcare journey. I know Ian and others have had some. We talked a lot about this last week when Ian was on, so we don't have to dive into it too much. But I'll start the way we should start formally. So who has seen what, and what have people noticed in the last week? Michael, I'm going to start with you.
Well, of course, the major story in healthcare was President Biden kept his promise, and not one American was hurt by debris from a falling Chinese balloon.
Thank God for that.
So that, and in addition to that major healthcare development, we also had the State of the Union address. And in preparation for this, I tried to look at the list of the healthcare items that he mentioned, which included capping insulin costs, fentanyl, mental health for the young, abortion, pandemic funding, the cancer moonshot ranging from smoking to navigation services, ARPA for healthcare research, veteran suicide, mental health, and telehealth. So I think that after he finishes being president, he's going to be a healthcare consultant.
Well, apparently it seems to be something that keeps a few of us busy as we get older. Although, he's going to be aging backwards by the time he's president. He wants to do anything else. All right. Vince, what have you been seeing?
Well, I'd like to ruminate over the CVS acquisition of Oak Street, and I will make a few prefatory comments, be a bit contrarian. What a huge deal. I mean, the amount of money that they're paying. The announced numbers, if you believe them, said 169 locations, 159,000 patients. And if you believe those numbers, that's an acquisition cost of $63,000 per patient. However, those numbers don't make sense to me. 169 locations, 159,000 patients, that would mean 1,000 patients roughly per location, which is about a half of a doctor. So something's wrong with the numbers. And I think that it's, to me, very interesting. Healthcare is very fragmented, and these large, big tech, big retail are buying a lot of physicians, but the market still remains fragmented. So take the One Medical that Amazon bought, and they got 800,000 patients, and that still leaves 329 million Americans who are not part of One Medical. So I'm going to speculate ahead. I mean, what I still see is a very fragmented marketplace, and the one inference you have to draw is that this is only being done with some sort of value-based care. They did talk about Medicare Advantage quite a bit in their press release, CVS did. But I think the next phase of deal making is going to be seeing deals across some of these large acquisitions. They may be business deals, or they may even be clinical deals where, for example, they got together to share clinical protocols or to work with insurance organizations. I don't know what those are going to look like, but I anticipate that that's going to be happening. And I hope we can talk a little bit more about the CVS Oak Health deal later on.
We'll definitely dive into that. The most important part, of course, is that I bought the damn stock years ago at $41 a share, and they're going to come out of, the cash bid is $39 a share. They could have paid another $2 a share to get me out whole, couldn't they? They have the money anyway. Interesting enough, CVS's stock has not been it's kind of close to its all-time high, which is 2015. which is before they bought it and did a whole bunch of this other stuff. So then they, if you compare their stock to United's over the last basically more than nearly a decade, hasn't gone as well. So it'll be interesting to see how that all plays out financially, let alone all some of the other things CBS will be doing. I'll be talking about that a little bit in the show as we go. But love to chat more about that. Mike, what have you been seeing this week?
Well, I've been continuing to follow the Dobbs case and the repercussions of that, because I had fought a couple of years ago to keep a chapter in my book Code Blue on how religion, evangelical Christians and Roman Catholics have, ridden the healthcare issue to advance their own agendas. So I wondered how far back this thing goes. And in some research this week, I uncovered the fact that the first medical society in the new colonies was in New Jersey in 1766. And its very first president was a physician and minister. And apparently at the time, there had been quite a lot of crossover and cross-semination between religion and science in the New World. After a decade of existence, the New Jersey Medical Society by 1976 had just 36 loyal members. 6 of them were pastors. So I thought that was kind of interesting that religion, at least in the United States, has been a rider on healthcare from the very beginning.
And everything else, actually. I think we can get into that in a sense, and still shows. I mean, I'm still fascinated as an immigrant here that in the State of the Union, it's all about God bless America and God bless our troops and God this, and don't forget, on the in the 50s they added under God to the Pledge of Allegiance, which seems to be contravening the First Amendment, but who the hell? Or as I say, under Canada. Anyway, Ian.
Well, I mean, talking about religion, I don't want to make you mad, Matthew, but Scotland beat England at rugby at Twickenham for the first time in 40 years.
Proper religious experience.
That was a proper religious experience.
Were the Scottish fans on the field ripping up the turf?
Yeah, I don't know. I didn't watch the very end.
I'm referring to the a game Ian knows well, the 1977 game.
Yes. Right.
Scotland beat England at Wembley, and the fans descended on the field and ripped the turf up. And
I might have been at that game actually, but
yeah, that was the sort of the highlight of Scottish evolution for the devolution at that time. Anyway,
yeah. But I mean, we talked a bit about the State of the Union. I just watched it again this morning because we had friends over the night and didn't see it live, but I thought he did really well. And the best line of the night was, he's going to go after resort fees in hotels that aren't even resorts, which I thought was, I don't know if that was an ad lib or it was written in. It was pretty funny.
It's amazing he knows about that. But on the other hand, doesn't the former guy have some hotels?
Yeah, have hotels. It may have been a subtle little. But here's what because we closed off last week when I was on we're talking about the thing that worries me is the unwinding of the public health emergency and what happens to all these people on Medicaid. And I am not convinced that there's going to be a seamless transfer over to exchanges. I mean, I just, I was listening to a United States of Care call on Wednesday, and I posed the question to their experts. And, given the variation in health and systems sophistication at the state level, it could be a bloody disaster and we could lose a lot of people. So I worry about that. And a related phenomenon I love to get a take on. I mean, Biden did a brilliant job of marshalling Marjorie Taylor Greene and the crazies into a box, saying they wouldn't cut Medicare and Social Security, but he didn't say a word about Medicaid. And so I worry a great deal that the battleground will shift to beating the hell out of Medicaid as a welfare program, in the debt ceiling debate. And 90 million Americans are on it right now. That's problematic.
Ian, although there's general consensus among the folks that I read and look at about putting the Republicans in a box about cutting Medicare, when I was looking on Twitter as this was going down, Avik Roy, one of the conservatives, was talking about, look how much the Democrats cut Medicare by calling the reimbursement limits on Medicare Advantage and other kinds of things like that, cutting Medicare. So while I'd like to think that the Republicans are in a box, I would not underestimate their ability to muddle the debate, but we shall see.
Can we try to fuse two things here? And this may be a hopeless case on my part, but there are kind of two things going on. One is, right, we've seen Medicare Advantage in the last couple of weeks being heavily criticized. As I think I said either last week or a couple of weeks ago, you cannot both believe that Medicare Advantage plans do a good job and come in under the cost of fee-for-service Medicare, and also believe they've been massively upcoding. And there was actually a great article by the pseudonymous CIO, Jane CIO, on his talk this week. I wish she wrote on THCB, but plug a rival publication. And I know her, she's actually a really experienced CMIO. And she was talking about, although George Halverson's been talking about how nurses can no longer go into the community to upcode and look for stuff, doctors in their EMRs are kind of encouraged to do revenue enhancement by checking off boxes about stuff they've done, and including, several EMRs have now, the consultants have sold to, tweaked EMRs so that doctors and clinicians were encouraged to sort of click up code, the conditions of the patients they have, and that was used for risk adjustment. And apparently there's some consultants are now going back, teaching you how to detune that so you don't get audited and sued, So at least the healthcare consultants, the tech consultants are making money both ways. But nonetheless, that's under real pressure. There's been the argument about, okay, we're going to audit going back to 2018 and fine across the board. We're going to audit all those audits that were done for the period between 2011 and 2018. We're just going to fine the $40 million out of that was done in, that was found in the actual people audited. We're not going to extrapolate that to everybody in the plan. So there's a lot of back and forth about how much they're going to get. But clearly that plus the cut to the only 2%, 1.5-2% increase in Medicare Advantage payments this year is, as Avik Roy said, going to be seems a cut, and the stock price was hit of some of United and Humana, etc., for doing that. So there is that pressure. On the other side, you've got what Don Berwick and Rick Gilfillan were talking about last year a lot and this year, which is the fact that the plans running Medicare Advantage are now going to say, okay, they're limited at the amount of money they can take off the top in Medicare Advantage for the plan cost. But if they integrate in the managed care, the Medicare Advantage groups, the people actually delivering the care, they can make a lot more money out of that. And then we have this week, the biggest single publicly traded Medicare Advantage medical group, Oak Street, getting acquired by the parent of Aetna. So I don't know. I mean, to me, this seems like this thing is kind of coming together, and you're seeing both Optum, now Aetna, to some extent Humana growing its groups, kind of wheeling their way to becoming kind of like, what we thought Kaiser without the hospitals. So I don't know, Vince, love your comments on this, or Ian to dive in on that a bit.
Yeah. The one thing about Medicare Advantage that isn't talked about, if you're young and you're healthy and you get all these extra benefits, it's a great deal. If you are sick and you don't like their definitions of what is medically necessary, you're screwed. And the reason for that I don't think people really understand is that your supplemental plan that you would probably want to buy can be community rated after the first year that you are eligible for Medicare. So if you're 75 or 80 and you come up with some kind of a strange disease that requires a lot of money, and the health plan decides we don't want to pay for it, you can be denied supplemental coverage, and you are stuck with the remaining 20% of the bill that Medicare doesn't cover. So, I guess I have qualms about the whole idea. It's great if you're young and healthy, but if you're sick, it's not such a good deal.
There's been a fair amount of publicity about, denials of authorization, having people reapplied, and prior authorization. There's been a fair amount of discussion about that, and I think Ian mentioned a couple of last week or a couple of weeks ago about this issue of, yes, you can't, those individual plans are individually underwritten. Some people are very suspicious that, the biggest pressure group on behalf of the seniors, ARP, has a deal with United Health Group where they make a lot of money out of those supplemental plans. So there's a lot of back and forth on that. However, I agree with you. I mean, it seems to me that it's really a one-way street. Once you sign up for it, it's very hard to get out. And the argument's going to be is, if you had George Alberson's piece or whatever, or those who look at it from the plan side, they say, no, the care is actually better. We have fewer foot amputations. We have fewer bed ulcers. We put all these programs into place in Medicare Advantage that Medicare Fee-for-Service has holes for. And there's a lot of, and I think that argument about, we don't have really good clarity about, how much of the stuff that's being denied is useless versus that story we had in the last week about I know it's not Medicare Advantage, but the kid in college that ProPublica had who was denied for his incredibly expensive drugs by United, even though they were working, whereas the other treatments they wanted to force him back to weren't working because they cost a lot less. We know the plans are practicing medicine to some extent. I don't know, Ian, what do you think about that part of it? And what do you think about the connection, for the plans getting more in bed and starting to own the delivery systems?
Yeah, well, just a couple of things, just to reinforce. I completely agree with what Vince said about, I was Medicare supplementary. I just got my supplementary bill yesterday or the day before, and my surgeon was paid 10 cents on the dollar in terms of charges, which just speaks to what a great deal it is that when you get old enough to be eligible. I talked to David Entwistle, the CEO of Stanford, and I was saying that I'd love to know how much he lost on my case. And he said that they lose $1 billion a year on an $8 billion base on Medicare. And God knows on the Medicaid side. But
the solution is that hospital in McAllen, Texas should come consult to them.
Yeah,
about how to make money on Medicare.
Wait. Is losing $1 billion, losing $1 billion what they wanted to charge?
Yeah.
Or is it losing $1 billion over of what their costs were?
Right. No, and that's Mike. You're right.
So it's presumably on their costs because what
they're
all trying to charge the charge master says 20 times, and the question is what they actually get paid and what their costs are.
Right.
But now, could they deliver? We've had this conversation with Jeff Goldsmith's been on, is that could they deliver, for the amount Medicare pays without, as Ian said many times, having to make it up by charging the commercial
right
3 times the amount. And the consensus whenever Jeff Goldsmith's on here is no, other than Ian found the one place in Texas where the answer is yes.
Well, I mean, before COVID, actually, I had a pretty big initiative going with Levitt Partners and Arnie Milstein and Mike Chernow and others. We were agitating about trying to get what we called Medicare Vanguard. People who are actually making money on Medicare level of reimbursement. There's one system who's done it consistently, Benefits in Montana, John Goodnow, who I've known, but that's the only place I know that runs the shop. Maybe the guys in Akron, Ohio, and the guys in McAllen, I think probably could make money on Medicare because they run a pretty lean shop. But anyway, I think we ought to get back to the original thing, Matthew, that you asked, and Vince raised at the outset, is making sense of the CVS Oak Street Health deal. I mean, I've always been a big fan of Oak Street because the flow of dual eligibles, and it relates to my point about Medicaid too. I mean, the reason why there's a lot of cash flowing through those things is because, and somebody may know the exact numbers, but the capitation payment for a dual patient is gigantic, and so there's a lot of opportunity if you do the front end stuff right, I think, to make money, even though they don't make money. I mean, in the deal that what they lose in something like. I couldn't figure out the finances, but it didn't seem to me that they were buying profit. I mean, they're buying up.
It's definitely so. Right now, I mean, whenever you see the Oak Street folks talk financials, I have done before, like at JP Morgan, where they're at is that they claim that they're making money on their old established stores that are doing well, but it's the cost of expansion to the new stores is why they're losing money. And so they had come up with this weird adjusted EBITDA number, which apparently is profitable. But it's very hard to see what's getting stuck where. But clearly, it's not a profitable operation. And same thing was true of One Medical. Even though they bought Iora, which was the other famous Medicare Advantage group, and they have their fancy sort of not nice rich people in California plan that service that I'm part of. They were losing money kind of on across the board, even if some of their places maybe already making money. And I think that comes to Vince's point, Mike. There may be 1,000 patients per facility. That sounds unlikely. There might be 1,000 patients of that age per physician, for a senior group, who are sicker than having typical panel of 2,000. But it seems to me is that, the counting and the funny math of how many people they've really got is a bit questionable, right? But the point that's the question I think is that can CVS now start moving, or Aetna or whatever, start moving money around within the medical payment, and can they start sticking it to hospitals more than they're already doing it, using their leverage from the health plan side as well as from the capitated medical group side, the dual eligibles. And I'm always struck because Mike, I think his name I will get his name wrong. Pitanesky, I think his name of the CEO, tells this story about, what do we really do? Well, we have people who go out to the bathrooms of seniors in neighborhoods in Chicago, and we put handrails in and we make it so they're less likely to fall and break their hip. And this is exactly the story that Al Burnett would tell at Friendly Hills, Ian, when you introduced me to him in
40 years ago.
Right? It's like, we've come a long way in 30 years. We're putting handrails
bath mats
in the house, right?
But I mean, God bless them, though. I mean, that is actually a good thing to do. I've always been a fan of those guys anytime I've had a chance to talk to them. But I think Vince nailed the real thing is they paid $63,000 per patient, right? How much scale does CVS need to offer? Because I worked with those guys when they were doing the merger, and I at first glance I thought it was stupid, but when you heard them talk about what the vision was to use the platform they had with Minute Clinic, that trusted relationship with consumers, the fact that they're 5 miles within 80% of Americans, as a platform, that's plausible. But how much scale on the doctor delivery side do you need to fulfill that in every market they serve? And I think the short answer is you'd have to spend a bloody fortune if that's your plan to acquire. I mean, I don't know. Has anyone done that math? I mean,
well, even United, who has the largest number of doctors, they've got 70,000 doctors roughly under employment. That's still less than 10% of the national marketplace. And maybe they have some concentration in a few regional markets, but that doesn't strike me for the most part as really moving marketplaces. I mean, you're right. The numbers you've got to get up to 20-30% of a market before you really have some influence to be able to influence prices and perhaps care patterns.
Well,
right. I think sorry.
No, it's all right. But I was going to say one variable is the scope of practice of the pharmacist. And, people say, well, that will never change. AMA and others would never allow that to change. But the reality is that primary care as a workforce and a base, which, we've invested a lot of time and energy and theory, and that's the way we wanted to go. But the reality is they're dropping like flies. Right. And we don't have the manpower. So now we're opting out for nurse practitioners and PAs. You can't even find them, and you got to go to urgent care, right? So in that type of a situation, it's not beyond the realm of imagination that we could broaden the scope of pharmacists. And when I talk to retail pharmacists, even the ones that just do the immunizations, they love patient contact, right? Love it. And they're more than anxious for their overseers at CVS to give them a chance to do that kind of work. Now, you'd need brick and mortar properly designed and so forth. But I'm just saying that there is a workforce out there that is underutilized and that is hungry to have patient contact. And it'd be interesting to see if we let them loose, what could happen.
Yeah. Like I go to my local CVS and Walgreens for the immunizations for flu and for COVID boosters, and they can't get enough pharmacists. I mean, they're not underutilized. Their knowledge is underutilized, but they're overstressed, and that's the problem. And all these promises that Walgreens and CVS and probably Walmart make, it's made by the guys in the executive suite, not walking by in the stores, and I've been to some of the Walgreens that were renovated to be, medical kind of places, and some of them that are not, and the same with CVS. And it's just a lot more difficult to execute this than you would guess from the PowerPoints, both in terms of the workforce and in terms of, do I really want to go to the CVS near me and sit in that little, area there and wait? Maybe they have a privacy screen, maybe they don't. I mean, there's a lot you have to change before the culture and the environment says primary care, as opposed to I hope you buy something on the way, a greeting card on the way out or whatever, right? And it may work, but it is far more complex and far more changes needed than when you're talking to Wall Street, as opposed to being at the at the front lines and seeing what it's really like.
Yeah, especially if you have to ask the patient to strip down and put a gown on in the hairspray aisle.
Well, maybe get some bigger attendance at CVS.
I'll be with you in a minute.
I got my first COVID shots. The first was sure you got to go anywhere. So I went to a Walgreens in Cicero at 8 in the morning, and there were various things locked up in the aisle near there, and crowded into the back. And then I got a booster at one in a very nice neighborhood in the city, and they're playing the oldies channel and plenty of room, but still the pharmacists are way overburdened, and good luck with all of that.
Mike's point's right, though, that the scope of practice is one tool, and there's various.
Oh, absolutely. If you give them the space, yeah.
The other one, I just got off the UCSF Grand Rounds, which today is focused on GTP3 or GPT, Chat GPT. Is the whole AI thing, and there was some kind of astonishing examples they were all given of the fact that Chat GPT could pass medical school with no problem.
So they say. Well, let me add a couple of things. So I think that the big picture question, pharmacists, what do you do with the stores? And I get that part. But the real question I think underlying is how far is this sort of movement by essentially big health plans? If you think of United Aetna, United Aetna, Humana going to this. So I would point out that today, ChenMed, which is size-wise about the same size as Oak Street, although it's still private, has just ended the deal with Humana, where Humana's going to, Humana, which is about 150 facilities. Humana itself has got about 250 own facilities. So, you're going down the path there where you have Humana, obviously the biggest Medicare Advantage plan, or at least proportionally the biggest Medicare Advantage plan. And I don't know if they have more enrollees than United does. United with Optum's got its 70,000 doctors that Vince just talked about. And now you have CVS, which not only has aggressively done this, but has also aggressively done a deal with Carbon Health, which, if you like, is kind of like a more One Medical sort of urgent care / commercial population competitor.
Didn't they also buy a home health delivery?
They bought Signify, which is kind of a home health thing, which used to be known as a way to do upcoding, but actually does a lot of integrating into. CVS bought that. So and then if you add in Walgreens, which doesn't at this stage is not yet owned by a health plan, or does not have a health plan, but nonetheless has bought aggressively into Village MD and is rolling that out at a massive rate. In fact, I had the Village MD CEO on a conference about 18 months ago, and he actually said that they were opening the stores adjacent to or inside Walgreens at a rate faster than Starbucks was opening stores, I think, in the middle 2000s, whenever Starbucks was growing, was in 90s when Starbucks was growing like crazy. So, I mean, I guess the question is, we've talked forever about, do we see, primary care and then capitated primary care? And I think, Robbie Pearl, when he's will be on in a couple of weeks, we'll talk about this as being a sort of, a vehicle that could transform healthcare if you could do it in conjunction with health plans. But the only people who've ever done it were Kaiser, right? And they couldn't grow to certain areas. So is this, longer term, going back to sort of, Joe Biden saying we're going to have oil around for 10 years, but then after that we'll all be driving EVs, which I think is about right. Longer term, is this the start of something really different in how everyone's going to get primary, if everyone's going to be Medicare Advantage and commercial?
I think it is.
And moving that. What do you, say more.
Yeah, so I would characterize it as we're in the Model T era of the corporatization of American healthcare, whether you think that's good or bad. This makes me think back to the article written by a couple of Andreessen Horowitz VCs a few months ago, and their argument was that the largest consumer company in the world is going to be a healthcare company. They put about a 30-year time frame to this, and it may be longer than that. And today, as evidence, though, you look at the market cap of United Healthcare in terms of worldwide companies in market cap, they're already number 8.
Yeah, I mean, you could clearly they could do it if they could spend the money, right? And they have but they have so many different revenue streams. I guess the question is, we're talking about a world in which there's been a slow growth. I mean, you mentioned, you yourself mentioned at the start, we only have, a relatively small number of patients,
right,
a small number of doctors in Oak Street. Add One Medical Iora, add Kano, add Agilon, add a bunch of these groups. You're not really getting to a massive total of where all the people are yet.
Not yet.
I mean, you could argue that and this is the question. I mean, Ian mentioned it's going to cost a lot of money, but maybe at 50, someone should work out in the back of their head what $62,000 a patient times the whole Medicare enrollment is. But it's a lot. What is that? That's a lot. That's certainly a lot of cash if you have to spend that much to acquire each one. But once you have this as a base, you can probably grow your enrollment and grow. If Mike's right, an extension of practice, you can probably grow the number of patients per and the GPT AI stuff and coaches rather than whatever. You can probably grow the number of patients per clinician per facility, and make that acquisition cost come down over time. You figure it out. I don't know how Starbucks did this, but I'm sure the first few Starbucks stores cost a lot, and the cost of them, went down over time. I guess the question is realistically, how much can these guys grow, and are their stockholders prepared to take the lumps that it's going to cost for a while? And I was looking at CVS's stock just to see what had happened, and it's still not back up to where it was in 2015, which is not for a stockholder, they're not great. Anyway,
right. Well, I mean, the story you said earlier, Matthew, was that I was on a board with a retail guy for years, and all he would ever ask about was same-store sales, right? I mean,
yeah.
If they're actually making money on a same-store sale basis with their early stores, that's a plausible, scalable deal, with enough capital.
Mm-hmm.
But the other issue, I think, is, Vince mentioned this earlier, is you don't necessarily have to do it everywhere. If you are market specific strengths, because that's my understanding of how United's played this. They identified whatever it was, 25 to 35 metro markets they wanted to go big in, and that made sense for them, and corral the assets that they've corralled in those markets. I mean, they're back in Southern California in a big way because of the acquisition of the old DaVita healthcare partner stuff. And so, I mean, you could do it selectively in various markets, but I think it's a real deal to watch. The problem,
but just interrupt. It's historically, and it's been Southern California, especially Southern California, South Texas, which I guess includes McAllen, right, and South Florida has been where because Medicare Advantage rates were particularly high there originally, way back when. And that's why, I mean, there are other places obviously with high penetration, but you know, it has always been a regional play for Medicare Advantage, and I wonder if it, you know, how much it can go national.
Yeah. Well, and I was hearing from one of my pals in New Jersey that the variant that they're seeing there was not so much playing off Medicare Advantage, but corral just primary care docs, trap the ancillaries around that, and sort of disintermediate the hospitals a wee bit, and use that as kind of a cheap lookalike of Margolis from way back when, not necessarily going after Medicare, but trying to do it on an insured basis. So, I mean, I think the real question is, if you do primary care right, do you eliminate enough of the downstream stuff? And that's where, given my recent medical experiences, I'm not 100% convinced of that. Yeah. You know, you look at the Commonwealth stuff. We have the lowest doctor visits in the developed world. We have the fewest docs per capita. It's not like we're overutilized. You know, in the grand scheme of things, we're underutilized on primary care. I agree, but you know, there's a lot of morbidity in this country. But I don't see us saying no to doing interventions.
While I was listening to you guys, I went and looked up the stock price of United Health Group. If you had purchased United Health stock in 2009, you could have gotten it for $18 a share. Today, it's at $4.85, down from a high of about $5.50.
Thanks for telling me that in 2009.
You just bought the wrong health plan, Matthew.
Funny on. Yes, let's not base this on my stock trading success. Otherwise, I'm still here, not driving my Ferrari around, unfortunately. Yeah, I mean, so I think that, I mean, it's an open question. I mean, my you know, I like to sort of tie a bow on this part of the conversation, and so, you know, what's the chances of success of, if instead of coming in from the outs, you know, we had the 90s, we had the Southern California medical groups, and then the physician practice management companies kind of trying to do this capitation thing. There was a lot of different flavors going on there, but it routinely, you know, it roundly failed. They couldn't make enough money. They couldn't scale. They couldn't get the capital. We've had another group now grow through the last decade or so, most of whom are now getting acquired by, you know, obviously One Medical is a big one, Iora is another one. Now we see Oak Street, you know, losing their independence, but in general being acquired by a health plan with a bunch of other stuff around it. You know, these big mega corporations sort of sucking them up. I mean, I guess the question is, you know, it goes back to Ian's point. Does it change what we've always done, or do people go back to like saying, well, fee for service is easier, we can find more stuff than you do, and you know, we can manage to shake it out that way? Or does it, you know, does it not change what we've done and go back to kind of, you know, more and more stuff being done? Or are we seeing a real sea change that's going to happen here, where we really are going to change the way we deliver care to seniors, and these could be, you know, these big corporations / platforms, as Vince might call them, you know, are going to grow significantly, and that's going to be the way the majority of, you know, we're 50% of Medicare Advantage people. Currently now about a third of those are getting their care in something that looks like this capitated group. Does that become somehow 60% of everybody or 80% of everybody, with only a few, you know, only a few ultra wealthy people being able to afford standard Medicare, and, you know, Stanford, you know, competing for the what was it you used to say, Ian, you know, the $800,000 hysterectomy or the $2 million bypass? So what's our sense about which way that's going to flow? Michael?
Hi.
Take yourself on mute.
You're on mute, Michael.
You're still on mute, Michael. He's not listening to us. We'll ask somebody else until Michael will come back. There he is. Now he's back.
Are we talking about whether the mergers are for people to take advantage of essentially market inefficiencies, right? I can do Medicare Advantage and scoop up all the money for the payment and everything else like that. Or with Optum, right, going to certain markets where I can control and therefore, you know, reap the benefits. Or are we talking about people who are trying to change the delivery system? And I'm, you know, yeah, the people they acquired all said that. I'm not sure after being acquired, that's what large corporate America will do. I'm honestly a bit confused. I'd be interested in what folks think.
My take is that this is really the pivot point, at least potentially, for value-based care and payment. And if you go back 10 years ago, primary care practices were being acquired by hospitals, and the economics there were we want to be able to feed our specialists and our beds and our surgery. And the economics of the acquisitions that are occurring today are 180 degrees away from that. They're folks, large corporations who are embracing value-based care and payment, and the multiples for which they're paying for these patients suggest that there's no economic way that they could run these solely as primary care practices. The numbers don't work. They don't even work for the existing hospitals who bought it. They're losing $100,000 or $200,000 per primary care physician. So, that to me is at least another way of framing all this. It's a huge push towards value-based care and payment.
Well, one thing I would wonder is, for a century, we've supported this notion of a triple mission for academic medicine physicians, where, we make believe that at one point, a single individual is a researcher, an educator, and a caregiver. And we've continued to fantasize about that, even as we freed up patents to the point where the guy who was doing a bit of research and education, let's say, now becomes a patent owner in a glass palace with a partner who's a pharmaceutical company or United Healthcare or whomever. These guys, and I don't know how many of them are truly left, are kind of the cornerstone of this whole way of delivering care. Some of them are not, bringing in NIH grants, but they're business savvy enough to be at the front end of United Healthcare and have figured out 50 years ago that if you buy physician data, you could flip that into institutional data, and you could flip that into a corporation that becomes the number 8 corporation in the world 50 years later. So, I think one of the ways, if one wanted to change this system, would be to take on that triple mission and say it's not allowed anymore. You can't have a triple mission. You got to decide. You want to be a caregiver, be a caregiver. You want to be an educator, be an educator. You want to be a researcher, join the researchers. But you can't be all three. You can't be crossing over. You can't be splitting the difference with your partners secretly. You can't do that anymore. So, I don't know whether it's feasible to take those guys on, but when I've been in closed rooms where I take them on face to face, they get really angry really quick, which suggests to me that it's a soft spot. It's something they know they've been doing, and yet have been able to grow and thrive through this system of kind of shared enterprise that nobody else sees as transparent.
Right, Mike. There are two gigantic engines of cross-subsidy in American healthcare. One is the one you described, which is the cross-subsidy of academic medicine, which is the clinical access funds the unfunded research and to a lesser extent the education stuff, because tuition doesn't cover the education, and most academic are spending more on research than they bring in NIH grants, right? So it's the clinical enterprises underwriting all of that. I mean, I've been involved in funds flow deals where, an academic medical center hospital is writing a $300 to $400 million check a year to the medical school, to subsidize faculty. And the other great cross subsidy we haven't talked about, which I think is still the rate limiting impediment to true progress, is what do the self-insured employers do, right? And unless Glenn Tullman's going to, come riding in on his horse and grow Transcarent into 100 million, 200 million lives, I just don't see enough progress on true value-based care in the employer sector yet. I mean, I'll be curious to see if the layoffs in Silicon Valley yield a little bit more backbone. But I don't know, Matthew, you talk to these guys all the time. I'd love to see some numbers on growth in that area.
Yeah, it's still, I mean, I think the answer is it's still not that much. The biggest company in that space is Included Health, and they've only got 10 million lives, compared to, I don't know how many, there must be 200 odd million. Sorry, 200 odd million.
180 million probably.
Million, quote unquote commercial lives, and a lot of them is still extremely messily managed. I would say that those cross subsidies continue, and they will kind of continue on. And what I kind of heard from Biden, going back to the State of the Union, that Michael realized, is that there is clearly stuff that's going to happen to Medicare, heavy Medicaid, within what CMS is doing with the Medicare Advantage, all the rest of it. But no one's going to seriously come after Medicare as a whole politically, and Biden will use that as he goes on and stomps on people who are suggesting on the Republican side. And while the way that it's been formulated on the Republican side is not necessarily great politics, there's been this ongoing argument forever about how ineffective Medicare is as a way of spending your money, and compared to I think I remember one of the first talks I ever saw you give, Ian, compared Medicare and healthcare spending to education spending for people under 18, and how we're consistently spending our money in the wrong place. We spend 18% of GDP, every other country spends 12. That's obviously there's this big cross subsidy from some cross subsidy from slightly younger people to older people in that, including via the backdoor way of employers paying more than Medicare itself. But I don't see any significant change in that. And then, you still got a cross subsidy, by the way, within the delivery system between essentially people who work for academic medical centers getting paid more for the same thing than people in private sector. I just had this situation where I had two identical back visits for my back pain. They were both very good telehealth visits, almost identical, same time, same information delivered. It was like almost a second opinion on the other. I was trying to get one visit, and two of them popped up in my appointments, so I took them. And I think the UCSF affiliated doc got 3.5 times what the private practice doc got for the same visit. And that's obviously the way that the health plans have agreed to sort of make that cross subsidy, and that's where the $300 million check to go right to the medical school comes from. So I don't see any massive change in federal policy when we say you can't touch Medicare to go after that kind of cost sort of opacity. So then on the other hand, you say, well, with Medicare Advantage, we're going to crank down the amount, we're going to have more capitation, and we're going to have more management by the primary care groups, and we're going to go after the hospital systems. Maybe, but again, I think that's tough to do because the politics involved is so tricky. So I trying to go ahead, Ian.
No. I was just going to build on that. The one forcing function that is evident, and California being the latest example. I was on a retreat a couple of weeks ago with Carmela Coyle, the head of the California Hospital Association, and our staff, but we passed a law in California for Gavin Newsom's, whatever he's calling it, the Office of Accountability. But basically what it is a replay of the Massachusetts model, where you set initially voluntary targets on total spend. Now, the net result of those things is sort of, there's transparency and, but what it ends up doing is shaming the expensive places and shining a very bright light on the fact that the Harvard teaching hospitals were getting 400 times 400% of Medicare or whatever. And I think, as this ripples through California, it will make evident the cross subsidy, and will also underscore the absolute dependency in this state on Medi-Cal, with 30% of California's on Medi-Cal. So, I remember a couple of weeks ago, there was a battle between Kim and Jeff about Intermountain. And I looked up the numbers from an obscure paper that a bunch of smart people did. This is 2018 numbers. Intermountain payer mix was 12% Medicaid, 20% Medicare, 68% other, which is mostly, commercial, right? Whereas Sutter was 23% Medicaid, 32% Medicare, and 45% other. So what's going to happen with the Gavin Newsom thing is it's going to exacerbate the scrutiny on commercial prices on the one hand, but it'll also reveal this dependency we have on an underfunded Medicaid system. So the financial hydraulics, I think, get amplified going forward by these kind of what I would call balloon in the box type models. And that might be the forcing function for all of this to get some rationality. Absent that, I think we've got these cost shifting engines. And the punchline from that is the Boston hotel workers managed to get zero premium increase and zero out-of-pocket costs by doing a very simple thing, which is leaving out every Harvard teaching hospital of their network. So it can be done, but it's brutal in terms of, network choice.
Ian, the numbers you in that study are shocking, but kind of hit me over the head. What accounts for the huge difference?
It's probably impossible to get on Medicaid in Utah as the first one, I would think. Not quite Texas level, but and then you probably have a different enough population there.
Younger population on the.
It's the last place in America everyone is having like 6 kids in their family.
Yeah.
A well-known
culture. It's a demographic difference, Vince, mostly. Yeah.
Okay. By the way, you'll also note that Intermountain moved its anchor flagship LDS hospital towards the area of town where all those young, well-insured families were living, because you really need to serve your community better, particularly when your community of well-insured people is moving. So they moved Temple Mount to, I suppose you could say, the Mount of Mammon. So
it's always been my advice: if you don't like your finances, move your hospital to an affluent suburb, Mike.
It works, and it's important to do community outreach. For instance, to have your cardiac outreach among well-insured people, because they deserve care too.
Yeah, exactly. Although I was a complete loss leader for Stanford. I mean, if you're on Medicare, God,
you have to catch the people who are just you have to get people closer to my age. I'll try to arrange myself to have a quick heart attack soon, so that UCSF or somebody can benefit. When we say that.
The only surgeries that I've seen in person were bypass like yours, and the first one I ever saw was in a cramped hospital in Long Island. It was an old place. And my first time in surgery said, step over this tubing right here to get to the head, which was the heart-lung machine tubing. It's like, okay, I'm going to be real careful here.
I'll step on it. My on the tube itself.
Well, my wife was a nurse in Canada on the first open heart team in Montreal in 1969. I said, how did they do it? And she said, well, they were in ICU for 6 weeks on a vent for at least a week, and they all died. So that was encouraging. Not so much now.
We've clearly got better. In fact, you read the Starzl stuff about how they did liver transplants, in the University UPMC. That took, that looked like terrible care for a very long time, and a lot of people died before they finally got that right. And I guess that's some ways how medicine advances, and where some of those excess healthcare costs go. Talking about excess healthcare costs, I will tell you a quick story about my attempt to come up with the solution to the latest healthcare crisis, which is the lack of Adderall and other ADHD meds, which is a really big streaming deal. If you get online in the community of people who have ADHD, which unfortunately represents a couple of young members of my family, there's a real crisis in supply, and a couple of things have happened. One is that, and there's a question as to how bad, whether this happened, whether this is an excuse made up, or whether this is what really happened. One is that clearly before this happened, during the course of the pandemic, this and other mental health conditions Whether they were there before and weren't realized, or whether they actually were exacerbated during the pandemic, there's certainly a lot more people with these conditions before than there were than previously. So that's one thing, and both my kids were diagnosed during the pandemic. Secondly, is that there are a lot of companies which establish themselves as online solutions where you could go get your ADHD meds. Cerebral was the most famous one. They've wound back what they've been doing, and they're not doing it to in some cases to no extent anymore. But and that sort of slowed down over the summer of last year. But since then, there's been this huge shortage, and apparently one of the manufacturers, Teva, has got some problems at the production plant and can't supply its demand or what have you. But it's ended up with patients really struggling to find the supply. And I had this happen to me literally this last week. Oh, and the other thing is the DEA, which in its wisdom has decided that this isn't a problem, and therefore they could have increased quotas for other manufacturers, but they declined to do so. So it turned out that a lot of people have been scratching around looking for this, and I actually went to my doctor, and she was calling around a few places and said, "Can you try and figure out where there might be some?" And I called a bunch of places. It's a bit weird because I don't want to tell you, and I say, "Come on, I don't want to have to send in an electronic script from my doctor to a place that you're going to have to turn it down because you haven't got it." The delivery pharmacy I usually use, Alto, kept on telling me they were going to get it, and they didn't get it. And then she told me they don't know when it was coming in, and I went to a bunch of other places. And I actually went as far as calling a bunch who didn't answer the phone. And I stopped by one, physically went in and had the pharmacist, it was a bit worrying this, the pharmacist says, well, I showed him the bottle of what we usually use. He said, I'll see if I've got any, but it's in a safe because it's a controlled substance. And he went up to the back of the safe. This was in a safe way in a pharmacy, opens the safe. I could just about see him do it. He says, it's on a 5-minute delay. So go buy yourself something and come do some groceries and come back in 5 minutes. So they made a bit of profit off me. But what actually happened was he then, I would assume he'd have this in some computer where he'd see what inventory he has. He's literally poking around with all the different bottles, picking up, going, oh, yeah. And I said, what have you got? And he was telling me what he had. And I said, how much have you got? I said, I've probably got enough for, for your kids to get the, to get the prescription and all the rest of it. And we ended up going across the street and getting the doctor to prescribe, into that pharmacy. So I actually got it. But it's been a real struggle for people to get that. And I think that, a lot of what's going on at baseline with patients is that they're not being, the systems that it is, it's very hard as a patient to figure out where this stuff is. It's very hard for doctors to figure out who's actually got some. And it doesn't seem to me that it's floating through to the DEA and others to say this is a problem that needs to be fixed. So, in a little world, you have to be, patients are going to have to be very creative. And there's a lot of online chat about, splitting pills and using caffeine for kids in the morning and doing all kinds of other things. So that's I like giving my people my little sort of healthcare update for the week, and that's been mine this week. So not fun. Yeah. Anyway, all right, we're getting close to the end, so let's have a quick go around and start what we think we're going to see next. We talked a lot about the big deal this week. I don't think anybody has any suspected big deals on their plate for next week or what else we're going to see, but what are we looking for in the coming weeks? So why don't I start with you, Michael?
Well, the State of the Union message is usually followed by the actual president's budget, which takes all these wonderful ideas and puts proposed dollar funding around them. So that will be interesting to see. And frankly, for those of us who are healthcare wonks, to dig into the non-headline issues, right, and start to look at what is CMS doing, what is FDA doing, what are some of the others, what kind of money are they getting things for, proposed at least, and see what happens. So that will be interesting. There's a lot of regulation and legislation proposed and all the rest of that never goes anywhere, and some that underneath the radar does. So that's kind of what we'll be looking forward to.
So on that one, just one quick one. So bipartisanship in a Congress which has Marjorie Taylor Greene Lauren Boebert or whatever going on.
No, the bipartisanship has traditionally been around something like NIH, right? We're all in favor of curing disease that we in Congress might get, plus all the money that goes to the universities in our state. So yeah, they're bipartisan on shoveling money into NIH, although after the pandemic, one never knows. And they're certainly bipartisan on earmarks, whether it be for defense or other things. But other than that, good luck. The CDC budget, I would expect, is going to have a lot of really fun hearings. And remember, all revenue bills by U.S. Constitution have to originate in the House. So that's a big deal.
Vince, what do you think? What are you looking at?
Yeah, I'm fascinated with ChatGPT. It's in the same aha category as the first time I clicked on a hyperlink and got to another web page, the first smartphone. Google has an analog, a medical analog, and they published results showing whereas the average clinician is wrong 4% of the time in their recommendation, their AI is 16% wrong. So it's clearly not ready for prime time yet, but I do commend them for publishing these results, and I expect and anticipate it's only going to get better over time. Exciting stuff.
It's very exciting stuff. I'm looking forward again to be able to aim it at my body of writing so that I can actually have it write my stuff instead of write it myself.
Vince, what happens if you ask ChatGPT what it thinks of Google's AI?
I think I'm going to go do that as soon as
I will tell you one thing. Yesterday, Google stock went down, I think, 10% because they put out a promotional video and there was their AI did
the worst demo ever, right?
Yeah.
Right. I want to see
a bit of a rough demo, but there you go.
Opinion about the other AI. That's it.
All right. Mike.
Yeah, I think there are two things going on behind the scenes that might be opportunities for people in the health technology fields. One is a group of sociologists linking up with physicians have identified the connection between a decline in visits to doctors and healthcare with an increase in fear and worry in the society, and are making the case that some of the problems we've seen with destabilization of the democracy are tied, in fact, to a lack of access to healthcare professionals during the pandemic. So basically what they're saying is the processing of fear and worry is a unheralded byproduct of day-to-day visitation and getting your worries dealt with by men and women who are health professionals. So reverse engineering that, one would say, if you want a strong democracy, you want to increase these types of access. You don't want to decrease them. The second opportunity is that back in 1816, when the first primitive stethoscope was invented, there was a rather radical shift because of that technology from hands-off observation to hands-on examination. And I think for people like Jean-Luc and others who are developing various different health technology adaptations, there is the potential to use this in the same fashion to basically insert oneself into the home. And, as Vince was saying, we're at the beginning of the real technological revolution in healthcare. And I think a humanized approach that allows fear and worry to be processed on the one hand and allows us to comfortably move from simple observation to a personalized kind of examination are fertile fields.
Yeah, I think that was fascinating that Biden really said in the thing, he wasn't talking about healthcare, but he was talking about community, that we've seen all these communities hollowed out and we've failed over the last, the sort of globalist thing, you could argue is over. I mean, he's arguing it should be over, and that instead of having, cheap consumer goods, our job is to build manufacturing in the heartlands and do all the stuff. That was a big sea change compared to any president since, God knows, Eisenhower or Johnson, talking about that. So I was fascinated by that. And you could kind of make a connection between that and the availability of healthcare, and sort of, worrying about, getting rid of people's fear and worry, because obviously we've had the sort of the Trumpist thing and the Tea Party thing in the last decade or more, indicating that there's a lot of people who are, if you allow a combination of fear and worry from many different angles to come at people, you might get some bad results. Anyway, Ian, finish this off and then we'll go.
Just on that, the last point, I would urge you to watch Grand Rounds from UCSF, which will be on YouTube tomorrow, because it was all about ChatGPT, and I actually touched on patient notes being written, in a sympathetic way, Mike, that fits with what you're talking about. So I agree with you and Vince on that. The one I'm going to be obsessively watching over the next 6 weeks is the potential unraveling of Medicaid with the public health emergency. And I think how different states react, who's going to win, who's going to lose. And it just seems to me, and it'll be reflected also, Mike, in the budget priorities. We start to see, whether the Republicans go after Medicaid. So I don't know. That's the one I'm really worried about in the short run, that we could lose. We could see a rise in the uninsured.
You're muted, Matthew.
Okay, you have managed to, thank you, Vince, for making me unmute myself. I don't know, I was muted at the time. You have been watching, listening to the THCB gang. Today, we had Ian Morrison from Menlo Park, California, Mike Magee from Connecticut, Michael Millenson from the peaceful, verdant city of Chicago, and although some northern suburb where he lives is probably very nice, and Vince Kuraitis from the urban hellhole of Idaho. Just kidding. What to do? We shall be back next week on February the 16th, just after Valentine's Day. I hope everyone will be getting lots of love and affection over the next few days in the build up to that. And I have the pleasure of going to see both my kids in their various school plays. Thank God the Adderall is cutting in. I'll be taking some so I stay awake through the whole thing. All right. All the THCB gang, I'm your host, Matthew Holt. Thank you very much for watching or listening on the podcast, and we will see you in another week.